progressed would be replicable. And believe it or not, this crazy idea was replicated on probably nearly 1,000 patients, and his extracts were called choline-toxins. And incredibly, today, he published in the Annals of Surgery in the 19th century. And if you see number 3, that's where he reports 3 cases of regression of cancer treatment with his erysipelas, his choline-toxins. So it could have taken it a very long way. But you know what happened? He was blocked from progressing in this field. Why? Because radiation came in, and the guy who was involved in this was a man you've heard of, Ewing Sarcoma. This is the man who basically said, this is dangerous nonsense, you cannot do this. And so that was the end of choline-toxins, and Ewing was actually featured in Time magazine around the same time, a week after Mahatma Gandhi was featured in the cover of Time magazine. So Kohli then was history, but today we know that he is the father of immunomodulatory treatment and cancer treatment and other treatment using these modern day therapies. We owe it to him. The father of modern surgery, William Halsted, was a risk-taker supremo. You know what he did? You might think of doing something adventurous on your kitchen table, especially when the children are away, but you know what he did was, he operated on his mother and removed her gallstones. And he transfused his own blood to his sister. I mean, at that time, blood transfusion was not known. He discovered cocaine. He was in New York at that time, and he discovered cocaine and used it for local anesthesia. And he not only used it, he advocated it and became an addict, and lots of people around him became an addict of cocaine. And he had to get that cocaine addiction treated with morphine, and things went downhill, and he basically had to move to Baltimore, and he started his career afresh in Baltimore. And there he did the riskiest thing possible. He married his theater nurse. And finally, he died of gallbladder surgery. His students tried to, residents tried to transfuse their blood to him, but he died. Barry Marshall, an Australian, and you know that he received the Nobel Prize for discovering H. pylori, but he drank the bacterial culture himself to prove that his theory was going to work. But not all risk takers managed to enter the Hall of Fame. This is a short story of the opposite of. Do you remember a couple of years back, there was a xenotransplantation of a pig heart into a human being, and the patient lived for a short time. It became news and was published in the New England Journal. But I know from personal experience, because I was very clued on to this story, Dhaniram Barua was a surgeon in a northeast Indian city called Guwahati. He actually did it so many years back, and he transplanted a big heart into his patient who died after 7 days from complications. He was arrested, and he was put behind bars for a fair amount of time, but essentially he lost his career at that point. So why do surgeons take risks? Because when you do it successfully, you can actually create a future. And the nature of our job is risk-taking. Risk involves not just the surgeon and the patient, but also our wider communities, and we all know that. For example, you know inherently there are so many patient categories which are high risk. I don't need to tell you that. There are so many types of hernias which are high risk. I don't need to tell you that either. But for a brief moment, especially for the younger people in the crowd, I want to just say, think in terms of how you can assess risk a little more scientifically. And One of the things which is used in many countries is the NISQIP assessment tool, which is online. So basically, you fill in the patient details, as you can see, starts from the age and it just goes on, and you get at the end of it, you get a certain number or a certain portion of risk for that given patient, and you can use that and proceed further, right? So, in the field of abdominal wall, we have the SEDAR app, which I suspect everyone here has read about, and some of you may be using it. And that is a validated tool for abdominal wall, but not for minimally invasive robotic, as far as I know, this to this point. This can be corrected. But regardless of all these risk assessment tools, the bottom line is, who is your patient, and do you really need to operate, and do you need to operate now, or you can buy time? So, apart from these risks, surgeon-specific risks, which are my concern, which are basically my focus area. So I have this notion, with my experience over so many years, of identifying stereotypes of surgeons, and I welcome you to identify which kind of risk taker you are. So the kind of cowboy surgeon who ventures into a dangerous field knowing fully well, because he doesn't have any fear and he breaks any rules possible because he knows he can do it. So going into that dark lane endoscopically, well, that's one example. And high risk taker acts on impulse. He is fighting a wall of bowel adhesions, very, very challenging, post-cancer, post-radiation, etc. And he says, I can do it. I have the skills, I can do it. And at the end of it, if the patient develops a peritonitis, he is wondering, how the hell did that bowel injury happen, and how the hell did I miss it? There's another type. You know the frog in the well? It looks at it, the whole world, with a particular viewpoint, a worldview, where the frog perceives itself as the ultimate, the biggest. So that surgeon operates on complicated cases without adequate exposure, and when the patient develops a fistula or some such outcome, denies his role in it and ascribes it to some extraneous facts. The thrill seeker loves novelty and the adrenaline high. This is a patient who had end-stage post-kidney transplant liver failure thanks to drugs, and he had rejection, etc. And he had a recurrent incisional hernia with loss of domain, which was threatening to burst, and I refused to operate. Behind my back, another surgeon operated and the patient died. Now this is a different type of risk taker. This is a strategist who is methodical, who identifies the risks, improves the techniques needed to mitigate those risks, re-evaluates his outcomes, and creates standards, and builds careers based on that experience and learning. Thank you, Dr. Hanniford, for your work. The hero sometimes is a very unlikely candidate. This is one of our young surgeons who works in a small rural town in India, and in the middle of the night operates an 85-year-old very sick patient with gastric volvulus or esophageal hernias which are obstructed and strangulated, and does heroic surgery and takes the risk, because this is a risk-averse society, and to take such risks is very, very creditable and a unique feature of some surgeons. So the surgeon stereotype is a key etiologic factor in AWR outcomes. How can we reduce those risks and improve our outcomes? Does evidence help us? Well, first question. It seems pretty obvious that an experienced surgeon would have better outcomes than a green one, right? So in the field that we work in, Charles Butler did this study, and the evidence from this study was that the recurrence rates of the experienced surgeon was less. Now, Vahan Napoleon and his team focused on high volume surgeons and their outcomes and the risk category that they worked in. They explored the database and had more than 9,000 cases, and they found that the high volume surgeons had more complex cases and they had the same outcomes for the soft tissue infections, etc. So, even though Yuri Novitsky said that if you're not living on the edge, you're taking up too much space, it is, at least in many instances, doing high-risk surgeries as a habit, as a practice, may actually be something of a behavioral disorder, and I'm just speaking my mind about it. So, living like this may become a risk in itself for the surgeon to develop an occupational risk, which I call as chronic hazardosis, which is basically that you're living life on the fast lane so much that it's killing you in more ways than one. So you have greater incidence of depression, alcoholism, divorce, lawsuits, lost jobs, financial ruin, etc. Many of these are identified in published studies, and I cannot go deeper into that because that's not really the idea. So, burnouts amongst our colleagues is significant. This study was from the US, and they identified nearly 10% of surgeons had a major blunder in the last 3 months, and they identified themselves as the problem for that outcome. So, managing risks safely needs more than the surgeon. It's not just about the surgeon, it's about your environment, and it's also about what you do outside the operating room. Now, what can we learn from those who have been managing risks very well? There are some common patterns. One, anticipate the risks. So visualize what those risks are, what those outcomes could be in worst case. And you identify yourself whether you have that within your scope of practice. This is a very, very important medical legal aspect as well. And you must ask yourself whether you're the right surgeon for that patient. That patient. And in case you land up in a complication, of course, every one of us who's experienced would say this: embrace your patient, embrace that complication, don't abandon that patient. Nothing works as much as technical skill in managing risky situations, right? This is very, very important because of all the adverse outcomes that happen, probably close to 70% of bad adverse outcomes happen because of technical incompetence or failures. And be a legend in communication. That is a very, very important way of managing risks and the outcomes. Let's go back to the start. So I asked you, would you get operated by this surgeon and you just saw this with your own eyes? This surgeon is Omar Ghanem. Many of you would know him to be a prolific bariatric surgeon in the Mayo Clinic. And this was his operation, right? And he actually accidentally opened the portal vein while doing a Mal's release procedure. And watch what happened. So imagine this. You have lacerated the portal vein and you have the gumption, the stomach, and the zen to control it laparoscopically without compromising the patient. Ladies and gentlemen, it's hard to say something funny when one is talking about risks, mortality, morbidity, and complications. but this is my lame effort. So my 2 pennies about this subject is that the boldest risks are apparently impossible, but at some point of time they become reality. But is this who you are? Is this what you are supposed to do? That is something only you can answer. Overall, trust is a very critical factor which lowers the cost of risk taking. Without trust, risk results in chaos. So before taking a big risk, make sure you have earned big trust. You either build an ecosystem of trust or you build an ecosystem of risk. It's ultimately your choice. Risks bring in complications in your life, in the lives of others, and because of that, risks make you humble. And I think the humility of all of you who have spent your time from your busy lives, away from family, coming to this meeting is something which is reflective of your humility, that you're sharing your time and your knowledge with us, and we are exceedingly proud of you. And ladies and gentlemen, thank you very much.